Hello everyone. Today we shall look at herpes and we shall look at herpes 1 and 2. My name is Dr. Abraham from A&D Dermatology, and I'll be the one taking you through this short lecture. So when you're looking at herpes, we have to be very, very serious because sometimes it looks a condition that people can easily manage, but at the same time, it can be complicated. So today we shall focus on herpes simplex type 1 and type 2. Then we shall have part 2 of this lecture where we shall look at the rest of the herpes from herpes number 3 for varicella. Then we have another session for herpes number 4 up to herpes number 8. You know, there are eight viruses in this subgroup. So for herpes simplex, the family, it belongs to a family we call herpes viridie, and major types, herpes simplex 1 and then herpes simplex 2. The mode of transmission, usually this is a virus that usually get from oral contact or through sexual contact. But this virus can as well be transmitted vertically, that is mother to child, and we see it to be part of the torches or those infections that mothers can give to their children. So herpes is a very common condition with a global prevalency, and if you are to assess the seropositivity in any population, it will be above an 85%. Though most of the cases are asymptomatic, but when it is symptomatic, it can also be bothersome. So in the structure, as you can see in this illustration that we see here, all viruses, they're made of a capsid. Usually this one's a protein capsid that encloses the DNA material. In this case, this is the DNA material inside. Then we have the capsid and then also the glycoproteins. Usually these ones are used when the virus is attaching to the different cell receptors of the target cells. So as we said earlier, herpes has a global prevalence, and if you look at this and this map, you see that we are having over 70 million cases in the USA. We have in Africa here over 134 million cases that are reported, and this shows you how common the virus is. So that means that almost in every 8 out of 10 patients or individuals you see, when you test them for seropositivity, they should have this virus in their body. So in the pathogenesis, we know that this virus, after infection, it will show latency. So when, for example, if you have intercourse with someone who is infected and they give you the virus, that virus will first attack your epithelial cells, where it will replicate in those cells with or even without symptoms. Then after that, they love traveling along your nerves, and they go and rest in what we call the ganglion, or in the sensory ganglion. So they will rest there and be in latent phase for eternity, until when you die, you stay with this virus forever. They only need a few triggers to be activated, and then this virus will move along this nerve to come and give you skin manifestation. So when we look at herpes infection, we usually classify it into 4 types. The first one, we call it the primary infection, which is now called the new episode, or the first episode that an individual gets. So this occurs when either you get exposed to an infected person, or you get it from your mother during the process of birth, or through sexual contact. So in the primary infection, that means that this individual is naive and has never gotten any herpes infection. So in these cases, you can have either symptoms, or you can actually go asymptomatic in this case. So if you get symptoms, they can include the sores, pain, or even a fever. Then in case you get another infection, you said you have type 1 and type 2 herpes simplex viruses. So if you get another infection with the second type of herpes, when you already have the first one, we call that a secondary infection. And it can even resolve without any symptoms. And since you already have some degree of immunity, or your body is aware of this virus, it gives milder symptoms, and it takes a short duration to heal. Then we have what we call recurrent infection. or activation. In this case, you already have the virus in your body, but it undergoes replication and multiplication, and then this is usually after stimulation, maybe by UV light, and then the virus gets reactivated, then it will give you symptoms. So some of the triggers that can cause reactivation of the virus include stress, any other illness that can suppress your immune system like HIV, or immune suppressive drugs like steroid, or even after transplant, you can have this virus giving you recurrent infections. Then we have what we call latent infection. In this case, you have no symptoms, but you're just sitting with your dormant virus within your sensory ganglion, and it is causing no symptoms. Then there's another term that we usually have saying the asymptomatic shedding. So in some cases, people can have the virus replicating and shedding into blood without necessarily causing symptoms. So that is what we call asymptomatic shedding. And in people who are infected, they can have even up to 6 sheddings per year. So this means that the virus is now moving around in blood. Then after that, your immune system controls it. And during these processes or during these periods, this person is very, very infectious. So if you are to compare the key differences between Herpes simplex virus 1 and 2, initially Herpes virus 1 used to cause oral infections, but because of the different changes in lifestyle and the sexual practices, it can also cause infections in the genitalia. Herpes simplex 2 was known to cause primarily genital infections, and less commonly it could cause oral infections. But now these two can cause either because of the, what I've mentioned earlier, changes in the sexual practices where people are doing cunnilingus and the rest. So you can actually transfer your HSV-1 to the genitalia and actually pick HSV-2 from the genitalia. And even cross infections are possible. So you can have HSV-1 and HSV-2 in the same individual. So if you look at the prevalence of symptoms among patients infected with SSV, we see that the majority, up to 60%, they usually have the infection without any symptom, but 20% can get symptoms that are actually recognized, and 20% actually asymptomatic. They never even get anything with their virus. So when we are to dive deeper into the conditions that are caused by Herpes virus infections, number one on the list and the commonest is the oral herpes, what we usually call the cold sores. And I think everyone has seen this before. And classically, it is caused by Herpes simplex virus 1, but currently even 2 can cause the same manifestation. This condition usually manifests with blisters, which can be grouped vesicles on the lip, and they love favoring either the angles of the mouth. You've seen them commonly here. Then they usually love being along this vermilion border on either the upper or the lower lip. But as well, you can have them in the oral mucosa, or even on the tongue, the soft palate, and even the hard palate. So the transmission is usually close contact with a person who is already infected. Either this can be through kissing, sharing utensils, and the rest. And usually the management, we can give all acyclovir, and we usually manage and try to minimize the triggers, especially UV light and stress. So in case of UV light, you can give a lip balm that has sun protection factor. So when you go to the second type of infection that can be caused by herpes is what we call hepatic psychosis. So in this case, you're having HSV-1 infecting the beard area. So in this case, someone can get recurrent folliculitis, which is now in this case a viral folliculitis that is around the beard area, presenting with pain, swelling. They can be pustule and grouped vesicles. And what you have to note about this is that it usually resolves in about 2 to 3 weeks, and the person will be okay. And then they will get another episode later on. So it is thought that it is just an auto inoculation, usually from the oral or Herpes simplex virus, but it can also be from primary contact if someone gets into contact with an infected person, then they spread the virus to their peers, maybe through kissing and cross-body contact. So the treatment we give antivirus. So you see in this case, we are having this beard area affected by the herpes simplex virus type 1. So the next variant or the next type of herpes infection, we call it the herpes gladiatorum. So this one used to be common in boxers and those people who do those fights. You know, when they're fighting, they're usually naked. And if you're fighting with an opponent who has an active infection with HSV, maybe on their lips, and then you come into contact as you are fighting, you can get actually this transmitted to you, and it used to manifest with grouped vesicles on wrestlers a few days after a fight, and you could see this manifestation still around either their neck or the shoulder area with grouped vesicles. So the transmission is still skin-to-skin contact during this fight with a person who is infected and maybe who is having active disease. So what people did after realizing this is that if someone is going for a fight, they usually do mandatory screening to see if they have an active infection, including all other conditions that can be transmitted, HIV, hepatitis B, hepatitis C, and all those other conditions that can be easily transmitted through blood contact. You know, when you're fighting, you can easily bleed out, and then you give your counterpart those conditions. Then the next type of infection that can be caused by herpes, we call it hepatic weight loss. This one used to be very common in health workers as before the introduction of gloves, you know, when you're handling patients who are infected and then you're touching into their blood, their excreta, their body fluids, you could end up with this viral infection on your hands. But now currently it is most commonly seen amongst children who love sucking their fingers, and they end up with this infection of herpes, usually from the saliva onto the hands. And it will usually present still with grouped vesicles, as we can see in this picture on the hands. So that is now hepatic weight loss. Still management is the same. So the next one that usually I fear most is the keratoconjunctivitis, because in this case, if you get infection of herpes that can affect your conjunctiva and the eye, it can even result into blindness. So this is a very serious type of infection, and it should be taken seriously. In this case, you have inflammation of the cornea, which we call keratitis, inflammation of the conjunctiva, which we call conjunctivitis. So you could have eye pain, you can end up with blurry vision, sensitivity to light, and if not addressed well, you end up with corneal scarring, even with loss of vision. And it is thought that it is transmitted by autoinoculation from any facial herpes simplex lesion. For example, someone has a wound on their mouth due to herpes, then you touch that blister, then you end up using the same hand to scratch your eye. So you can end up actually auto-inoculating the virus into your eye, then you end up with keratoconjunctivitis due to herpes infection. This can also be caused by both HSV-1 and 2, and it usually requires urgent treatment. And in this case, you have to involve the ophthalmologist. So you see in this picture, this patient has this keratoconjunctivitis. You will see this post-inflammatory hyperpigmentation and hyperpigmentation at the border, but then we have this scar formation on the conjunctiva with blindness. So to avoid this, you have to do early treatment. So when you are to look at the clinical manifestation of herpes simplex virus keratitis, we need to understand that this is now further classified depending on what you are affecting. So it can be a primary infection by classification, depending on the location of the disease. It can be on epithelial, it can be on the stroma without ulceration, or on the stroma with ulceration, or even on endothelial cells. So in this case, each type of infection of the eye can give a different manifestation, and it usually requires different treatment, but this section is better managed by the ophthalmologist. So in this case, if you're a dermatologist and then you see someone with hepatic keratoconjunctivitis, the good thing to do is to send them for an urgent ophthalmologist evaluation. So the next type of infection that we usually get from herpes is the genital herpes. Now, in this case, typically caused by HSV type 2, but even type 1 can cause the same. And someone will present with recurrent painful blisters or ulcers in the genital region. And these recurrent outbreaks will give you the idea, because this condition never heals. You know, the virus, we have no cure for it. So it will present very many episodes with the same manifestation. It's just as grouped vesicles, they rupture, and then they end up with erosion and usually get a prodrome of burning, tingling, or pain sensation in the same areas. So still, the transmission is usually sexual contact, but now we can now include other things. So it can now be caused by the sexual practices that someone does actually. And the management, usually give antiviral medication, and then you advise safe sex practices, including use of condoms. So because of this change in sexual orientation, so men who have sex with men, you can have this manifesting in the perianal area. So as we can see here, we are seeing these grouped erosions which erupted from an initial grouped vesicles. So then we can have herpes affecting the innocent ones, the newborns, and the intrauterine fetuses. So in this case, it can either be HSV-1 or 2, and then the transmission can depend. So if it is intrauterine, we call that vertical transmission, that is mother to child via the placenta, or it can be in the perinatal period during birth, as the child is passing through the birth canal of the mother, then they get infected with this virus. So the manifestation in neonatal herpes, that means that the child has this condition before they make a unit is a child less than 28 days. So that is 1 month. So they can present with a syndrome which you call SEM, that is skin, eyes, and mouth lesions, or they can present with disseminated disease. In that case, this is a severe form, or they can present with even encephalitis. So this is very key to notice, because you can have loss of children as others are still thinking about maybe birth asphyxia. They are now thinking about maybe possible birth trauma. Then when the child gets a fever, they think about neonatal jaundice. They rarely think about viral causes as cause of this neonatal unwellness, fevers, and convulsion. So if every time you have a neonate having fever and convulsion, you have to think about herpes, because if you don't, you can end up losing that child. And usually the management, you have to give IV acyclovir as early as possible. Then we have this special variation or variant of herpes infection, which we call eczema hepaticum. So eczema hepaticum is the manifestation of herpes in a child who already has atopic dermatitis. We know that when you have atopic dermatitis, you have a defect in your skin barrier. So in this case, instead of having the localized infection of herpes in these children, because of already deranged skin function, you can get disseminated herpes. That is what we call eczema hepaticum. So in this case, you have vesicles, pustules that can spread all over with can also be presenting with the systemic symptoms, and you can also get secondary bacterial infections and scarring, and you have to give antiretroviral therapy immediately. For example, in this area that we see here, so the child is even ending up getting these lesions even around the eye, so they can even get Herpes simplex keratoconjunctivitis, the one we've seen earlier. We see the same lesions, grouped vesicles around the mouth and everywhere. And then since the child is atopic, you can see the central pallor and then periorbital darkening and then Morgan folds around the eyes. So you have to treat these patients very fast, because they can end up complicating. So which treatment option do we have? So local available, we have acyclovir, valacyclovir, and then famiciclovir, and then this is given depending on weight of the individual, and it can be used in both primary and recurrent infection. So in preventive therapy, to prevent outbreaks, usually we give what we call suppressive therapy, and in this case, you can give maybe acyclovir twice a day, depending on someone's weight. So if it's an adult, around 400 milligrams twice a day for about 6 months, even up to 1 year. And then after that, when you give a drug and then someone gets a recurrence, still you continue with the same suppressive therapy. So this can be very working in patients who have immune depression or compromised immune system, like HIV patient, transplant patients, and patients on corticosteroids for a long time. So you can end up putting them on chronic suppression. Currently, we have no vaccines that are approved, but research is ongoing with hope that maybe if you could get a vaccine, this could help a little bit better. Then, when you go to the management strategies, so one, you have to make sure that one, you tell the patient to practice safe sexual practices to prevent a spread, that is use of condom, abstinence for those that need to abstain, and also making sure that you are not on the sexual network. Then you avoid close contact if someone is having an active outbreak because they're infectious. You have to avoid contact, and then proper hand hygiene, especially in hospital settings. And you have to identify the trigger and avoid them. If it's stress, illness, you address the underlying condition to prevent outbreaks, and then use of antiviral medication. So what are the differentials? So depending on where the location of the rash is, you can think about other things can present the same. If the rash is then on the oral cavity, we can think about abscess ulcers. These ones are also usually recurrent, just like herpes infection. We can think about hand-foot and mouth disease, which is caused by the circuit virus. We can think about angina, or that those give oral lesions. If it is genital, we can think about syphilis, chancroid, and then also even yeast infections like candida. So if it is skin, we can think about impetigo, contact dermatitis, varicella, or if it is presenting with the systemic symptoms, we can think about erythema multiforme and SJS. So we shall also have a section on erythema multiforme and the different triggers, and we shall see that in most of the cases of erythema multiforme, up to 90%, the trigger is Herpes Simplex virus. So those are the differentials to think about. So how do we investigate our patients? So depending on your locality and where you are, you can do investigation depending on our variability. So if you're better placed, you can do viral cultures where you can actually isolate the virus and then culture them in stem cells, and then you can actually coin that this is Herpes Simplex virus 1. So that would be the gold standard. But this is usually time consuming and less sensitive, especially in late stages. Recovering these viruses may be a little bit tricky. Then we can also do a PCR. This is usually very sensitive but expensive and not readily available. We can also do direct fluorescence antibody, the DFA testing. This is also less sensitive than PCR, but it usually gives quick results, but still not available in our setting. So what is available in our setting, what you can do actually, we can do the zinc smear, but in this case, what do you do? So if someone has, this is their blister, what you do, we usually deroof this blister, and then you get a slide, you remove cells at the base of the blister, then you stain with GEMSA and then look at those cells under the microscope. Then you'll see giant cells, giant multinucleated cells, epithelial cells that could give an impression of what? That could confirm Herpes simplex virus infection. But this is not specific because even varicella gives the same impression, even and CMV, cytomegalovirus, gives the same impression, but at least it can give an idea. And this is usually sensitive. Their sensitivity it depends on the user. If someone has done them multiple times, you can actually see good result. If someone has never done them, you can fail to see results. Then the other tests that are available, we can do serology where we do antibody testing. You do titers for IgG and IgM antibodies, and this one will help you to detect whether it is an active infection, recent infection, reactivation, or even latent infection, depending on which is positive. And then, if someone has CNS involvement, you need to do a lumbar puncture. And then, in this case, if you are suspecting encephalitis, like in the neonates, you have to do a lumbar puncture. And I know in training, if a child gets a convulsion, you cannot do away with a lumbar puncture because you need to confirm how the CSF looks like, because it can either be fungal, bacterial, or even maybe a febrile seizure if the CSF is normal. So in this case, a lumbar puncture may be paramount, and then on that fluid that you get from CSF, you can do CSF analysis. Can also use the same fluid to do a PCR and confirm the presence of HSV. Another test that can be done is biopsy, but this case it is usually done, and then if you do it, you will see cytopathic changes that include intranuclear inclusion. So you need to do special staining to see that. All right. So if it is an immune suppressed patient, usually HSV becomes a mess, becomes a menace, meaning that in this case, you can see a typical presentation. Instead of seeing the normal grouped vesicles and maybe blisters, in this case, you can see multiple extensive ulcer wounds that are not healing, which are recurrent, because these people have usually depressed immunity. So it can even affect multiple sites. It can be disseminated, it can be verrucous, it can be exophytic, it can present like even a deep fungal, like a deep fungal infection, yet it is just simple HSV infection. So in this case, you need to really investigate this patient and see if there's what is the underlying condition. Like in this case, if you look at this patient, you can think they have a deep fungal infection on the nose, but in actual sense, after investigation, you see it is HSV. So what should we take away from this session? One is that HSV type 1 and 2 are widespread and they give a lifelong infection. As we mentioned earlier, after they have attacked your epithelial cells, usually they are taken up by the nerves, move retrograde into your sensory ganglion, rest there, and those are immune protected sites. So your immunity cannot fight them. They only come out when reactivated. Then two, it presents how can I say, in multiple forms. As we've seen the different variants, we've seen hepatic Whitlow, keratoconjunctivitis, gladiatorum, we've seen genital, we've seen orolabial, and we've seen it presenting different types. So this is a condition that can present in very many forms. And you have to do early management to make sure that you address the complication, especially in the neonate, because if you don't, then you can end up losing those babies. So I will thank you for your concentration and watching this video. Remember to subscribe, put a comment, and share with your mates so that they can get the same information. I remain Abraham from A&A Dermatology Specialist.